Good morning, everyone. Today we are exploring a fundamental transformation in how we understand and treat high blood pressure. We are moving away from seeing hypertension merely as a systemic symptom to be managed with daily pills. Instead, we are entering an era of molecular cartography where we identify the genetic and the pathogenic root cause of the disease to silence them at their source. To understand where we are going, we must look at three scales of cardiovascular focus. The first one is macro systematic scale. Our traditional foundation focusing on hemodynamics, blood flow, and vascular resistance. The next one is hepatic or genetic scale. The current frontier of precision molecular targeting. Here we use tools like RNA interference to silence the production of angiotensinogen in the liver. The third one and the last one is endothelial intracellular scale, the emerging frontier where we unmask hidden pathogens like cytomegalovirus that drive inflammation and disease from within the vessel walls themselves. Let's review the classical hemodynamic balance. Blood pressure is the product of cardiac output and systemic vascular resistance. Cardiac output is driven by heart rate, contractility, and blood volume. Vascular resistance is influenced by blood viscosity and vascular compliance. Clinical hypertension is defined as a blood pressure greater than or equal to 140 by 90 millimeter mercury. And our traditional goal has been to manipulate this macro variable to achieve normotension. Our current gold standard first line therapies target these systemic levels. Diuretics reduce blood volume via the renal system. Beta blockers lowers the heart rate and cardiac output. ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2. Calcium channel blockers inhibit the smooth muscle influx to reduce resistance. While effective, these all share a common weakness. They require perfect daily adherence and often come with systemic side effects like cough, fatigue, or edema. This graph illustrates the adherence cliff. Traditional oral pills result in peaks and valleys of drug concentration. If a patient misses even a few doses, suppression fails. Conversely, the RNA plateau represents a new evaluation. By targeting the genome directly, we remove human error from the equation, providing stable long-term suppression regardless of daily behavior. This is the mechanism of zilebesiran, a small interfering siRNA. It works in three steps. First one, entry. It selectively enters the hepatocytes. Second, integration. It binds to the RNA-induced silencing complex. And the third one, cleavage. It specifically targets and destroys the mRNA for angiotensinogen. By rewarding the mRNA, we halt the synthesis of the precursor to angiotensin 2, turning off the RAS system at its absolute source. How does this compare to traditional ACE inhibitors or ARBs? In target level, traditional drugs target receptors or enzymes. Zilebesiran targets messenger RNA. In site of action, traditional is systemic. Zilebesiran is highly selective to the liver. The third one, duration. In duration, traditional lasts 12 to 24 hours. Zilebesiran lasts up to 6 months. So we are moving from reversible receptor blockade to mRNA degradation. The Cardio 1 trial data is remarkable. A single subcutaneous dose of zilebesiran at 150 mg, 300 mg or 600 mg showed a sustained 24-hour ambulatory systolic blood pressure reduction of 14 to 17 millimeter mercury. Most importantly, this efficacy lasted for the full 6 months period, demonstrating marked target engagement and suppression of serum AGT. Cardia 2 trial showed that zilebesiran isn't just for monotherapy. When layered over existing first-line medications like amlodipine, indapamide, or olmesartan, it provided an additional 4 to 12 millimeter mercury reduction in systolic blood pressure. This proves it provides additive, clinically meaningful benefits even for patients already on stabilized regimens. Safety is paramount, especially with a 6 months irreversible dose. First one, tolerability, highly favorable with mild injection site reaction being most common. Second, monitoring. We must watch for hyperkalemia, hypotension, and minor declines in kidney function. The protocol recommendation is routine monitoring with a comprehensive metabolic panel and EGFR. And now we shift to the most recent molecular cartography. While genetic therapies optimize how we control the RAS, new research is unmasking a covert variable driving hypertension from within the endothelium: persistent cytomegalovirus infection. In this precision matrix, we see that mouse cytomegalovirus infection alone causes a significant increase in arterial blood pressure. Critically, this occurs independently of lipid metabolism, weight gain, or atherosclerosis. While a high cholesterol diet exacerbates the issue, the virus itself is a primary driver of the hypertensive state. The mechanism here is a non-lytic hijack. The virus persists in the endothelial cells without destroying them. Instead, it forces the cells to actively secrete pro-inflammatory cytokines like interleukin-6, TNF-alpha, and MCP-1. This persistent viral inflammation damages vascular mechanics and directly alters hemodynamics. Perhaps most shockingly, we have found that higher viral loads directly correlate with increased renin mRNA and protein expression within the vascular endothelial cells. We have visual confirmation of CMV antigens and renin granules co-localizing in the same infected cells. This results in elevated angiotensin II levels detected directly in the serum and arterial tissues. This brings us to a synthesis insight. We have two opposing forces in a single ecosystem. The upstream brake. Genetic therapies like zilebesiran that stop the system of precursors. The downstream accelerator. Viral pathogens like CMV that covertly hyperactivate the exact same RAS pathway. The virus is essentially turning on the system. However, most advanced therapies are trying to silence. What does the future hold? High-risk frontier. Cardia 3 is currently testing zilebesiran in high-risk patients with resistant hypertension. In cardiovascular outcome trials, phase 3 trials are planned to prove long-term mortality benefits. The viral management, we are investigating if antivirals or vaccines against CMV could act as a preventive measure for idiopathic hypertension. In conclusion, hypertension is no longer just a hemodynamic symptom to be managed daily. It is a complex molecular architecture to be mapped, silenced, and as we continue to uncover its root causes, ultimately cured. Thank you for watching this lecture video.